We aren't good at explaining prognosis. So, prognosis, as we describe it, is an anticipated trajectory and or morbidities patients in the pediatric intensive care unit might experience during or after an ICU admission. So, really, by the time of PICU discharge, only 61% of parents and 59% of attending physicians recalled having any sort of prognostic conversation. This is in comparison to our initial study that looked at the occurrence of prognostic conversations at 5 to 10 days after PICU admission. At that time point, 88% of parents reported having any sort of prognostic conversation. So our new results show that we either aren't explaining potential new morbidities, we don't explain it in a way that parents understand, or parents don't remember what we say. We focused on prognostic conversations because compared to adult literature, research is limited. So communication literature in pediatrics tend to focus on what's being said in family conferences, creating and reflecting on communication education curricula, and evaluating perspectives from bereaved parents and bedside nurses about communication during a child's life at end of life. So in the last 10 years, post-intensive care syndrome, or PICS, is just starting to be explored in pediatrics. And at this point, there are more questions than answers. So we thought it was important to explore what parents recall about prognostic conversations relating to potential post-ICU morbidities, if physicians agree with parents, and with whom parents have prognostic conversations, and really, if parents want to know more about prognosis. From here, we can begin to explore how parents interpret prognostic information and use that to create a multidisciplinary curriculum for trainees, nurses, social workers, chaplains, and physicians about prognostic language that is more understandable for patients and families. At the time of PICU discharge, one would think the team provided anticipatory guidance of what life might look like after PICU discharge. At least it was my hope. In the end, we found a need for improved communication, with more than half of parents wanting more prognostic information. At discharge, parents most commonly recalled having prognostic conversations about potential physical morbidities, need for tracheostomy, long-term oxygen requirements, surgical gastric tubes. These are changes to a patient's daily life from a quality and function standpoint. Least commonly discussed conversations were those pertaining to potential changes in cognitive capacity, memory, learning, as well as psychological changes. Interestingly, though, nurses and social workers tend to play the biggest role in providing anticipatory guidance relating to both patient and parent psychological morbidities. From a physician perspective, I don't remember receiving formal training in how to talk to parents about potential psychological or cognitive morbidities. I've learned the most about these subjects only after experiencing them firsthand or with loved ones. I also think that physicians probably perceive other aspects of care as more important or more acute, or perhaps that these prognostic conversations may appear more time consuming. So, from the standpoint of a multidisciplinary team, it's hard to get all the players in one place at the same time. So, unfortunately, it's easier not to talk at all. So, this becomes a challenge with a multidisciplinary consulting, rotating team members, really. So, if the same people stay on 24 hours a day for 365 days, this would be less of a problem, right? In reality, we need to be better communicators with each other and with families. Some institutions have implemented pediatric ethics and communication excellence rounds, peace rounds, that invite the multidisciplinary team into a space to talk about more complex patients. Other places promote improved communications via rounds or in the electronic medical record and an easily accessible location.